Hello, welcome to TAS presentation once again. After the conference, this would be the first presentation of its kind. Uh, I could not make it due to some personal reasons, and this is what I prepared for those conference, and hope this helps those people, those who are interested in ICU. Basically, what we are talking here is last 40 to 50 years, ICU has changed and lots of intervention has come. Some has worked very well, some did not work. So, what are those 10 important interventions you'd be doing it, and what are those 10 interventions which caused a lot of harm to our patients with or without our knowledge? This will be a totally evidence based presentation. As you see, the reference which was taken here by Landoni et al., published in Critical Care Medicine 2015. What they have done, they have taken uh, lots of studies together and they have found out really what are the intervention in ICU had worked and what are those interventions that had harmed those patients. They have taken all critically ill patients, those who have high mortality rates. As I said, many RCTs over the last 50 years. The objective was to find out which treatment affect mortality in a positive or in a negative way. So, study types, they have taken all those meta-analysis, all multi-center randomized controlled studies of any kind of intervention and influenced by unadjusted landmark mortality. What were those inclusion criteria and exclusion criteria? They have taken a non-surgical ICU patient. So these are all pure medical patients with more than one organ failure. They have taken all those peer review publications with multi-center randomized controlled studies. Statistically significant results they have included here. What does that mean? I'll describe in the next slides. They have excluded all those preoperative or surgical or pediatric patients. The sample size were overall median sample size was 200, 199. It's quite a good number, and some of them are in thousands. Overall median of at least 10 centers where should be involved, and number needed to treat to get one patient benefit is 7. It's quite a high. I am not going to explain NNT or NNH. That number needed to harm is average, median was 9. So these are quite a good number. NNT of 7 means something like very, very good results. So first, let's go and find out what works in ICU. We'll be not talking about Zygris and dopamine in renal protection. These are out. What are the current things which is working? All right. Steroids in head injury. So we are not talking about those obvious things. These are the completely relatively new things. So what is better to do at present in 2016? What are those evidence supporting interventions? The first one is non-invasive ventilation, your BiPAP or CPAP. This is studies extensively. This has been studied extensively. 8 randomized controlled studies, around 1,000 patients. A category of patients of COPD, hypertensive, hypoxic respiratory failure, we are talking about pulmonary edema I mean, acute pulmonary edema due to the hypertension um, and results. And a patient who has been weaned from ventilator or liberated from ventilator, the usefulness of NIV with a NNT of 5 to 10. This is probably the highest understanding we are getting nowadays, that non-invasive ventilation we should all be having in ICU, and we should be trying it in this particular area. Another area which is getting into view is terminally ill patients, so cancer patients. So those who want to die peacefully. So NIV is the number one positive response in critical care, according to this uh, article. All right. Mild hypothermia after cardiac arrest. HACA studies, 9 center, 275 patients. They kept a targeted temperature of 32 to 34 and NNT of 7. So, mild hypothermia after witnessed in hospital cardiac arrest has a tremendous positive outcome. All right. So, this studies, although it is published in 2015, it has not taken the count into that Swedish studies of targeted temperature management, which says that you just avoid hyperthermia. So basically, according to this paper, mild hypothermia after cardiac arrest works very nicely. NNT of 7. Number needed to treat is 7, means you treat 7 patients, 1 life is saved. All right. Prone positioning in severe ARDS. Now, 27 center, around 500 patients, prone positioning for 16 hours, then standard treatment plus standard treatment alone, NNT of 6. So, prone positioning in severe ARDS done early has a very good outcome. So, this is the intervention we should be doing it. Low tidal volume ventilation. 3 studies, severe ARDS, very good NNT. Nobody denies that even we are talking about low tidal volume in anesthetized even for the 2 hours, 3 hour surgery. This has been talked a lot in anesthesia literature at present. So, but in ICU, low tidal volume is the way to go, NNT of 3 to 11. Now, tranexamic acid or TXA in high risk of hemorrhagic shock and trauma patient. You know that CRAS trial, CRAS 2 trial, one study, but 247 centers, 2000 patients, tranexamic acid versus placebo, NNT of 68. It looks very it's not a good number, but if you think of the price of tranexamic acid, you do not lose anything. It's a very low cost intervention, and the absolute risk reduction of death, according to, if you go for the statistics, it comes 2%. So it's quite a good number, as per the statistical point of view, since they have done lots of lots of patients with those intervention, tranexamic acids, not only in trauma, in severe patients, those who are about now potential bleeding for anesthesia, especially in total hip replacement and major surgeries where the chances of bleeding is high. We have been using it and we know that it works. So basically in trauma, where there is risk of high chance of hemorrhagic shock, so tranexamic acid is a proven technique now. It should be used. Now, daily interruption of sedation in ICU for liberating patient from ventilator. 4 centers, around 350 patients, one study, daily spontaneous awakening trial plus SBT versus spontaneous breathing trial. The daily spontaneous awakening trial plus spontaneous breathing trial versus the conventional spontaneous breathing trial. So, if you do a daily stoppage of sedations and awakening the patients with spontaneous breathing trial, the chances of getting the patients liberated from the ventilator is quite high. All right. So, NNT of 7. Now, albumin in subacute bacterial peritonitis and hepatorenal syndrome. One study, seven centers. Albumin and like steroids, you give it, the results are even for fluid, for anything, it's not very convincing. But here, in subacute bacterial peritonitis and hepatorenal syndrome, 7 centers and 126 patients, antibiotic with albumin and antibiotic without albumin, uh, the results were quite different. So, basically, in those patients, the albumin is depleted, and those antibiotic is carried, by high protein bound in nature. So, basically, you give them albumin and it reaches those infective sites more easily, probably. So, NNT of subacute bacterial peritonitis and hepatorenal syndrome treatment is 5. All right. So, let's see what are the things that did not work. So, these are the things which should be done now. What should not be done? Which are the bad intervention? Which are the things which increases the mortality? Apart from things like dopamine and in renal protection, Zygris, steroids in head injuries. So these are the things which has been proven to be unsafe. Now, what are those newer things we should be taking care of in not harming the patient is hydroxyethyl starch. Now, hydroxyethyl starch in septic shock or sepsis was very popular in recent past. In 26 center, one large studies around 800 patients versus ringer acetate in severe sepsis, they found number needed to harm. What they found? Basically, they found that the sepsis patients are getting one more organ failure, that is the renal impairment and needing renal support and dialysis and mm, so basically, so this HES hydroxyethyl starch should not be used in patients in septic shock resuscitations. Now, this might be a news for so many people. High frequency oscillatory ventilation, they found in 39 center around 550 patients in moderate to severe ARDS patient, high frequency oscillatory ventilation versus low tidal volume ventilation with high PEEP, the number needed to harm with high frequency oscillatory ventilation is 9. It's quite high. So, jury is still out, but this study, which has come up with a good number of patients, probably saying the indication is the more harm than good in high frequency oscillatory ventilation in ARDS patients. So, probably low tidal volume and high PEEP is the way to go. All right. Supranormal oxygen delivery. What is that? 2 centers, 100 patients. This is not the 100% oxygen or hyperoxygen therapy. So, what they have tried is the patients given a more amount of oxygen to be delivered. They intended to deliver more oxygens by getting more cardiac output using dobutamine and IV fluids and all those things. So that the oxygen delivery to the tissue would be high, all right, because you are increasing the cardiac output. So they found that by doing that, you are harming the patient. So you do not need to intend to do a supranormal oxygen delivery to your septic patient or ICU patient, those who are in sicker state. Intensive insulin therapy, you know that the Belgium study, which has come in 42 centers, 6,000 patients, patient expected to have at least 3 days in ICU, a very tight control. They did 81 to 108 versus less than 180 milligram per deciliter. The number needed to harm was, more than 38. They found more incidents of hypoglycemia, more cardiac events, and no increase in, or decrease in ICU length of stay or anything. So intensive insulin therapy, you remember 4 5 years back, everybody used to have every hourly insulin therapy, mm, uh, very rigorously done. It's now not being done because they found that it is causing more harm than good. All right. Okay. Now, what else? The other things which is which is to be taken care is use of IV salbutamol in ARDS, diaspirin, cross-link hemoglobin in traumatic shock, glutamine supplementation in sick ICU patients, and growth hormone treatment. So these are all causing harm. So you should not be thinking about all those interventions. Now, limitations. The data which was incorporated or utilized or taken is before 2013 and but published in 2015. The trials were not very big, uh, not very well quantified. Now, this is something new, something amazing. All right, a brand new study published in 2016 is uh, is 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 this something amazing. A brand new study published in 2016, all right, the accuracy of point of care ultrasound to identify source of infection in septic patients, a prospective study. All right. So this is the article. I would like everybody to have a look on this. 22% increase in accuracy of diagnosis. 24% of the time they had to change the antibiotic after finding the source of sepsis by ultrasound. As per the guideline, appropriate antibiotic directed to the bug and the type of tissue or type of organ intended. So they were more accurate in 24% of the time. Now, we know that how much culture time takes and how much to identify the patient to go for a CT scan to find out. So basically, time taken to diagnose a disease specific thing which caused a sepsis is only 10 minutes if you are able to use. By the way, these are all professional and by ultrasound, and they do it daily and in their emergency room to ICU. So it is not that the novice can do it, but thing is that they were novice one day. I mean, just it's a ultrasound has itself come over to medicine or medical practice apart from radiologist very few years back. So these are the things they looked for: pneumonia to endocarditis to renal abscess to appendicitis, infected kidney stones. So this is what the exact value was saying. So likelihood ratio of 16.1, okay, with ultrasound. Without, it is 3 point. It's a good number. Just have a look on those negative likelihood ratio, positive likelihood ratio, sensitivity and specificity, accuracies. All are jumped up like amazing results. So uh, please try to utilize ultrasound as much as possible in your clinical practice. It has become a stethoscope sort of thing. So if you know how to use it, you will be a hero. All right. So what are the take home points? Use of NIV, targeted temperature management in post arrest patients, low tidal volume ventilation, prone positioning, tranexamic acid in traumatic hemorrhagic shock, and albumin in cirrhotic patients in subacute bacterial peritonitis. They work. They work. There is ample of evidence. Even if you know it, just consolidate your knowledge. Okay. Stop using hydroxyethyl starch, high frequency oscillatory ventilation for ARDS, intensive insulin therapy, um, uh, supranormal oxygen delivery, trying using dobutamine and all stuff. So, and lastly, the biggest of all, use ultrasound. You'll be a different doctor altogether. Thank you very much. Hope you will like it and let me know your feedback. Thank you very much.